sharing our ideas. Let's make it more profitable. Feel free to chip in. We share. I learn something. You also learn something at the end of the day. As my colleague attributed, my name is Christopher Mweenda, one of the senior radiographers at Withington and Manchester Loyal Cath Lab. And today's presentation is the IVUS in cardiology. Basically, it's one of the equipment we use more often nowadays in the Cath Lab. Okay, so in layman's language, actually, intravascular IVUS is just a catheter-based procedure used to see the inside of coronary artery. Because in the Cath Lab, we are basically dealing with the coronary arteries, and these are diseases. So if you want to see what is going on inside, that's the equipment we like to use. In this topic today, we're going to look at just the basic science and the when and why we use IVUS, and we look at a lot of images so that we have an understanding of the IVUS, and obviously we'll look at the interpretation, lesion assessment. These are the things you find in when you're intervening using IVUS. Okay. Okay, the basic science, IVUS, obviously you use a probe like in any ultrasound we use even at home, but the essence is to look at the blood vessels. It's used sound, obviously everyone knows about it. Ultrasound can be used to focus the well-defined beams. Then at the end of the day, you have an image, which is called an IVUS image. When we are using IVUS, we rarely use a lot of X-rays. We minimize that, okay? So, but you can use the X-ray when you want to screen where your catheter, IVUS catheter is, but basically you use a lot of ultrasound, and which in the benefit to the patient because you are giving less dose to the patient. That's part of it. This is the IVUS machine, and I think though some of you have not seen me for a long time, this is how I've aged now. Okay, that's a Boston Scientific IVUS, which we use at the Withington and the MRI. So with the IVUS, it comes with the extended equipment which we use. The first one, this is what we call MDU. That's the motor drive unit, which works between the catheter and the imaging. Okay, and this is the catheter which we use in the IVUS. At the end of I've given a slide which I've shown you what the catheter is and how it is made and the imaging process. Okay. Okay, that's a slide. It's part of the equipment which we use. The essence of the slide is if you put the MDU on the slide here, and the slide is attached to the MDU and the catheter. So what will happen is, obviously, we pull slides. It's give you the sense of when it's pulling or sliding, it's taking pictures. That's the essence of this. Usually you use more when you are doing it automatically, and manually, it's basically the doctor or the radiographer just pulling the catheter. And I will explain more about the automatic and the manual IVUS. Okay. That's the catheter, how it's made. Basic thing, that's the transducer where it rotates to give you an image. Yeah. Obviously, you can see the flushing point. In the Cath Lab, the important thing we do is we always make sure that we flush the catheter. We don't allow air to, because once you introduce air in the coronary artery, you create air embolism. So it's always important when you are using a catheter diagnostic or catheter intervention, make sure that you flush the catheter. There is no air introduced in there. So that's how the catheter is. This is the guide wire. You can see it's on. A guide wire is in the Cath Lab. We use the guide wire to take us to the position of the lesion we want to get to. Because if you use the catheter only, you can create dissection. So the guide wire first, it will go in there. Once you put the guide wire, then you follow it up with the catheter. So the question is, why using IVUS? because you can do an angiogram, which is a gold standard, and it will give you an assessment of coronary arteries. And I think in the last presentation, I also talked about coronary arteries. The basic coronary arteries we use, we assess in the Cath lab are right coronary artery. We look at the left main, which divide into the circumflex and the LAD, which is the left anterior descending artery. These are the major arteries we assess. However, when just doing an angiogram, the information you get is not enough. So you have a limitation of what you can see. You cannot see the internal details of the vessel or the O of the vessel. And by using IVUS, it will help you to improve the patient outcome in terms of you give the patient the correct stent, the correct measurements you get, and obviously it will also make sure that you help you with the measurements of where you want to put the stent. Okay. So when do we use the stent? When do we use the IVUS? Sorry about that. We use the IVUS machine when we want to see, we want to stenting. So we want to see what size of the vessel is this and what type of a stent is required. A stent, usually I can put it, I know there is a lady who is at I think it's Lusaka Health, they do. A stent is more like a scaffold. When you open the vessel, you want to maintain it open. So the only way to maintain the vessel open, you use a stent, which will be left there, and it remains into the patient's body for the rest of their lives. Okay. The other thing we use the IVUS is if we want to assess the lesion, what type of the lesion you are dealing with. Is it calcified? Is it thrombus? All those things. You can also use the IVUS if you want to assess the stent you have put in, if it has been well opposed, which means is the stent, when we put a stent, it has to attach to the vessel wall. So you need a balloon to push it outwardly to attach to the vessel wall so that it can remain there. If it's not well attached, sometimes it can move, and that would be a danger. Okay. So the other thing, you can use the IVUS if you look, you're acquiring thrombosis, and also you can use the IVUS in in-stent restenosis. In-stent restenosis is whereby a patient who has been put a stent, and usually it comes with patients who are not taking their medication. So the clots usually, the plug usually they develop, and they develop inside the stent. So you can use the IVUS to diagnose that. The other thing you can look at undersized stents. If you put a stent, as I put it earlier on, the stent should, when you put a stent, the stent should be close or should be attached to the vessel wall. But if it's not attached to the vessel wall, that's what we call undersized stent. And the other cases whereby the lesion is too long, so you need to put two stents. So you have to make sure those stents are overlapping. You can only find out that the stents are overlapping by using the IVUS. In the complex PCI, more especially when you are dealing with the left main stem, this is a complex case whereby, because when you lose the left main stem, then that's the cardiac arrest. You are dealing with fatality there. So you need to have an IVUS to guide you. This is one of the tools when you are doing CTOs. Those are CTOs are, I can call this a chronic total occlusion. This is a occlusion which has been closed which has not been open for some time. So if you really want to open, and these most patients, they would go for theater, but maybe they are turned down by the surgeon, so they come back to the intervention. So you need to do the PCI. So we usually do a CTOs, and the IVUS plays an important role into these cases. Okay. Again, when do we use IVUS? Obviously, IVUS is good for people to look at the normal vessels. I've got some images of the normal vessels, diseased vessels. You can understand, okay, I'm dealing with a disease. So what type of disease, what type of plaque I'm dealing with. There's concentric and eccentric plaque. Because if you have a dissection can happen whereby, like I have said it earlier on, is a dissection will come up if there is the catheter is left unchecked, it moved, it's obviously it's usually happen with the inexperienced operators, they will cause dissection. Yeah. But if you want to check if there's a dissection, you can use the IVUS. Side branches. If you, I can give an example of left anterior descending artery. The left anterior descending arteries have got smaller branches, which is called diagonal and septal. So just stenting, you're putting a stent. You have to know your landing zone. So side branches will help you to decide where you're going to land your stent. All right. How do we image? There are two ways of imaging in IVUS. One is called the manual pullback. Basically, this concentrates on the lesion which you want to see. And usually it is the doctor or the radiographer who's doing the procedure, just pulling the catheter, concentrating on the specific lesion. Okay, and we have got an automatic pullback. This is whereby you image the whole vessel. And if we go ahead on some slides, I showed you the slides where the MDU sits. That is the purpose of that. It's just it moves on its own. It takes the whole image. Okay, so basically these are the two ways if you want to take an image. Well, we also look at the IVUS images. This is a normal IVUS you would find in an IVUS image. That's the first thing you need to know. You can see this is a healthy vessel. To learn how to interpret an IVUS, the first thing you have to look is the media. You can see the media. This is the media. It's very clear. Okay. And you've got the lumen inside, or they will call it the intimo. Okay. That's the adventure, which is the outside the vessel. Here, sorry about that. Sorry. That's the catheter. That's the IVUS catheter, which is taking your image. Okay. This is basically how a normal vessel looks like. So it's always important you understand how a normal vessel looks versus to a diseased vessel. So just to take a breath in a normal vessel, just for a part of the interpretation is, you can see I've learned outside of the vessel, that's adventure. And here, that's the ring one. This is the ring. The first thing you need to identify, that's the media. When you know the media, then the second, you can start identify other areas. The second is the intimo, which is the inside of the vessel. This is a normal vessel, which is not diseased. If you look at this, this is constricted plaque. You can see the plaque is distributed around. This white stuff you can see, that's the plaque. The vessel, that's the vessel. So you can see the lumen has been narrowed because of the plaque. You can see, oh, this is a plaque. That's a diseased vessel. Okay. So this is an eccentric plaque. In eccentric plaque, the plaque is distributed regionally. It's not round. You can see we have got a plaque here. It has reduced. That's your lumen. That's your lumen. And here, if you can see there, that's your media. Okay. After giving you, and you can see the side branch coming out here. That's your side branch there. So you have got different plaques. You've got the calcified and fibrous. The fibrous plaque is echogenic. You can easily identify there. You can see if you go between, if you look at the clock, between 4 o'clock and 8 o'clock, here. That's a plaque which has built up in your blood vessel here. Okay. So definitely this case, obviously, this person is having angina, and it's because of the plaque which is coming. And you have the media here. Outside there, you could see the adventure. Okay. So we will look at another plaque which is called calcified. In a calcified plaque, you see, because it's so thick, the light cannot pass through. You to always create a shadow. You can see the shadow which is being created because of calcified. So this is inside your vessel, and you have got this plaque here, which has been built there. So it has narrowed your blood vessel because of plaque. So they obviously this patient needs to stenting at one point. Okay. So another thing we can look at is the under expanded stent. See, you've got how you identify a stent in an IVUS. It's called threads. You can see those threads coming up. These are the threads. You can see them. Those are the threads. But as I always said, first thing in an IVUS, you look at the media. This is your media. That's your vessel O. So you can see the distance from here to here. There is a big distance there. And I think earlier on I said a stent needs to be opposed so that it is attached to the vessel wall. So you can see the stent is not well expanded there. Basically, in this case, what they will do is they will measure the vessel wall, then they will look at what type of a balloon they can use. They will put a balloon in the stent and balloon it, make sure that the stent is pushed outwardly towards the vessel wall. But basically, this is how an under-expanded stent IVUS image looks like. You would find there is a space there. Okay, so this is a good stent. It's been well stent. You look at the distance between, this is the stent. You can see the threads there, and that's the lumen, and that's your catheter. That's your media here. And look at the distance here. It's almost attached. It's well attached to the vessel. That's a good stent position, and I think they have put a good position of the stent. Yeah, in that case, obviously, when you have such kind of image, you just take final pictures. Then you are done. You have done your work. You have done. You don't need to do anything. So now I want to look at the stent which is male position. If you look at the IVUS, you have to understand first. You look at your media, and you start looking at your threads. These are your stents. You can see there is a big distance here. So it's not well posed there. It's not well attached. So you need to balloon it, to put it so that it pushes out. That's the other thing. You use an IVUS to look at those things. You can see there is a side branch here, which is coming up here. That's during the IVUS. So side branch will help you, as I said it more, to determine when and where to put your landmarks and where to put your stents, obviously. Okay. You can see this is the inside of your vessel, and there is your side branch coming up here. It's the same image. Sometimes you create, there is thrombi in the artery. How do you identify it? This is in an healthy vessel. If you look at well here, you have got the media is well defined here. Then you have got the intimal. You can see there is no plaque here which is coming up, although that's tiny. It's not started. It's just tiny. It will not affect it. It has not narrowed it there. But here is the thrombus well. It is well defined here. You can see it. developed. That's the thrombus. So an IVUS will also help you to identify or to diagnose thrombus. Okay. And I talked about the dissection. Obviously, when there is a cut or a tear, if you would use IVUS to look at where the problem is, and you can. This is the right coronary artery. If the disease, the right coronary artery. Okay. If you look where I'm pointing out, you see as the same as I remember when Mr. Kanyesha was teaching us radiography. I think Mr. Banda, God knows where he is. Yeah, he always teach us when you are looking at an X-ray, you have to know where there is a split. Yeah, you have to follow the line. It's the same principle even in IVUS. If you are looking at the dissection, if you look at it, you can see the line here, it breaks. There is that break there. That's on an ordinary angiogram you are looking at. Now you employ an IVUS there. This is how in an IVUS will look at. You can see there is a tear there. That's how you identify dissection in an IVUS image. You can see the first thing I've always tell when you're looking at an IVUS, you look at the media, this ring. When you identify the ring, that's the first thing. Then you know this is adventure. Then this, you can see it inside there. That's the intimal. That's your catheter. The distance from here to here, this dot is to present 1 millimeter. But in this case, our focus is to look at the dissection which has occurred. And this is and we employ an IVUS. You will look at the image. This is how your image will show you how the dissection has. And if you combine with now an angiogram, you can see it is in the midsection of your right coronary artery. And in this case, if you look at it, obviously you cannot leave it. You need to stent. So you can stent from here. So you see this as a side branch there. This is a side branch. You don't want to go beyond that. So if you're using IVUS, you know, oh, I cannot go beyond the side branch. I'll stent from here and here. So this is covered. A stent, as I've put it up earlier on, it's just a scaffold. And the patient needs to be on aspirin for the rest of their lives, obviously. And some of the patients who come back usually after stents are the patients who are not taking their medication. Obviously, in an IVUS, you cannot always have straight line things. There are sometimes you have artifacts which will occur. As a radiographer, I'm sure everyone look at you like if you are an engineer. So if you look at, this is one of the artifacts whereby there is no rotation. This is a type of image it will give you. So you have to understand, okay, this is this, what should I do? The only thing you can do here is just to change the catheter. It will give you better image. That's one of the rule of the thumb when you have something like an artifact. And sometimes we usually send back the catheter to the manufacturer and they give us a new one. Okay. So there are some times whereby you have got air bubbles I've introduced. I've talked to you about when I was showing you the catheter. It's always important that you don't introduce air in the arteries or you cause air embolism. So by adventure, obviously this happens to what trainees we call registrars here, and they who are training to be cardiologists. They are the one doing the IVUS, so you are working with them. Obviously, they depend on you guys as radiographers to guide them. So if they mess it up, sorry to use that word. If they make a mistake, this is how it will look on the IVUS image. These are the things you should be looking at. Okay. Then I thought of when we look at IVUS, what are the safety and the complication? Obviously, when you use IVUS, we use literal radiation, which is good to the patient. As I said, if you're doing a CTO, this is a chronic total occlusion. This procedure usually takes a long time. Basically, when they are planning for, if you are doing a CTO, it usually takes about 2-3 hours they would give. Sometimes they would give 4 hours because they know it's a long procedure, because sometimes you have to go antegrade, retrograde until you finally open that vessel, and it takes long. So when you are using IVUS, you reduce radiation. Obviously, we know, everyone knows as a radiographer, radiation protection should be your cornerstone. The second thing is it improves the patient outcomes. Obviously, the patient will come out from the procedure having the corrective stent. The stent is well placed, and the stent will also look at any abnormalities within the stent which can be dealt with. So it is a very nice tool to have. And also the other thing which can complicate is dissection. If you are moving the catheter not well, you can perfilate or dissect there, and it gives you another problem. Then you start now stenting the region which you were not supposed even to stent. Another thing I've talked about is air embolism, which can be introduced if you're not flushing your catheter. Thrombus, I've talked about it. Sometimes if you are moving the catheter, you sometimes people go into the ventricle, they need to cause chest, to cause some arrhythmia, which is changing of the heart rhythm. Obviously, it needs to be controlled. So all those things are some of the things which can cause complication in an IVUS. Okay, some of the key points which you have to learn when you're doing an IVUS is there are three layers, arterial layers you need to talk. I think I've always talked about adventure. This is the outer layer of the vessel. So you need to know when you start looking at any IVUS image, when you look at the outer layer, that's the adventure. Then the inside there, this is the most important thing, the middle layer, which is called the media. It is the ring one. The ring, once you start identifying that ring, then your IVUS knowledge will improve, because now you will start. Because what happened is most of the consultants, they rely on your IVUS measurements. They go, can you do the measurements? So the first thing when I'm doing an IVUS, I do is when I take an image, you say, okay, first thing, what should I do? I find the media. When I identify the media, then I can find the internal. Then I can, the adventure, I know this is the outer area, but the media and the internal, because these are where the plaque burden will be. Is there any question there? Hello?
I don't think so.
Okay, that's fine. So the other key points which you need to know when you are doing IVUS, the doctors always, can you give me minimum luminal area? Okay, so as a radiographer, cardiac radiographer, you need to know if you are doing the left anterior descending artery, what are the measurements you should be aiming for? If it's a normal one, it should be more than 4 millimeters. So if you look at CX, that's the abbreviation of circumflex. Yeah. And the RC, the right coronary artery, it should be 3 millimeters. Then the left main, that's the main trunk. Yeah, that's the main trunk. It should be more than 6 millimeters. So these are the basic measurements. If it's lower than that, the measurements, then there is a plaque there. Or sometimes the plaque is too much. You cannot do a PCI. Then you have to, obviously, let's take it to the surgeon who can intervene, because sometimes not always all the disease can be cured or intervened by the cardiologist. Some will have to go to the surgeon. Like a 3-vessel disease, basically most of these cases, they'll go to the surgeon. So these are the key points. If anything, you have to pick away from this talk. And I just gonna emphasize again, the IVUS image. This is the 3 most important areas you just need to know if you have to, when you're doing IVUS. You need to know adventure, media, and the internal. Okay. So I know it's a short, what will IVUS help us? Obviously, it will give us correct measurement, and correct image interpretation will improve patient outcomes. which is obviously it's been well documented. Most of the patients who use the IVUS, the outcome has been brilliant. And in nowadays, this tool is well used in this part of the world. Any cath lab, they always have an IVUS. And some of the cath lab now, what they are saying we have now integrated the IVUS in the X-ray machine there. So basically, it is one of the most important tool in the cath lab, which we use most, about 80% we use the IVUS nowadays. And obviously, at the end of the day, as a radiographer, you want to reduce radiation. Any complex PCI, CTOs, IVUS is your tool to be used. It will help you and give you correct measurement, to point you where the region is, point you what type of plaque you are dealing with, point you the length of the stent you can use to protect that vessel. So this is a short talk I had presented to you, and I've prepared, and I know sometimes I'm going to talk about the OCT. That's another tool which we use in the cath lab. At this junction, I would like to, and anyone who has got any question, we can discuss, try to educate each one of others. So it's an open, no one knows everything. Everyone knows something, and we learn from each other.
Thank you very much, Mr. Chris Mweenda, for the presentation. Yeah, I can see a hand from
Kalenga.
Yeah, Kalenga. Please, you
Kalenga. What's the question?
Good evening, everyone. Please bear with me. It's my first time ever hearing a presentation about cath lab. I just wonder, how do you insert the catheter, and how do you locate the particular coronary arteries? Is there something special? What really goes on? Is the patient, are the patients put under anesthesia? Just out of curiosity. Thank you very much.
No. As I said, one of the things my pastor used to tell me he said, there is no wrong question, no, we are here to teach you, to learn from each other. Fine. What happened is, I'm gonna get to one of the, okay. Let's take this image as this is the IVUS we want to do. So first of all, you have questioned how do you get to the heart? Everything we do in the cath lab ends up to the heart, okay? So there are 4 ways we can get to the heart. Most of the time nowadays, we use the radio artery. So you use they puncture a small ore into your radio artery, then they'll pass through a wire, which will go to your heart. Are you with me, Kalenga?
Yes, sir, I am.
Okay. Yeah, so they will puncture a small hole on your radio artery, usually on your right side. Okay. Then they will pass through a soft wire, which will go to your heart. Okay. When you go to the heart, obviously we usually get to the aorta, the ascending aorta, because at the ascending aorta, that's where you have the root for left coronary and right coronary artery, right? So when you get the wire, and as a radiographer, it's the same basic things that when they tell us you go to the theater and do the screening. So you need to be screening to guide it where the wire is. Sometimes they will struggle to get the wire through the arm. So you screen the arm up to the heart. Then they will get the catheter. So I'll show you one of the catheters. Yeah, that's the catheter. This is the IVUS catheter. It looks like this. First, you have got the wire here. So you get it to the heart. Then you get the catheter. Same principle, the catheter will go through, the catheter will pass through here. Now, the wire, you've got the wire, you've put it to your heart, right? So then you get the catheter. The wire is very long, it will come out. So they will put the catheter on the wire. So then they will push the catheter to your heart. Okay, so you can go through the right radio, left radio, but the problem you have with the radio artery is because the artery is so small, so it goes into spasm. So usually you would find the patient cannot tolerate that. So you end up using femoral artery. So you get me from there. So you use the femoral artery, the right femoral artery, or the left femoral artery. In this case, when you do puncture there, you need also to take a picture of the femoral artery. Why do we take a picture of the femoral artery? Because we want to rule out if there's any dissection. And at the end of the procedure, you also put a plaque, like a, what can I say, a cap on it. But for the radio, what you do, there is what we call, I know there is a lady who works in the Cath lab in Lusaka. I don't know if they have got, there's what we call tiara band. It will just more like a plastic which tighten the wrist so that you stop bleeding. And after 2 hours, they will remove it. So now we have dealt with, this is how you get to your heart, right? So once you get to the heart, then you can see this is the right coronary catheter here. So you need to engage into the right coronary artery. You can see this is the right coronary. It is ending here. That's you've got here. Those are the branches there. So you engage. When you engage, you use the dye to identify, because obviously the density of the coronary is low. You cannot see anything. So you have to fill it with the contrast media. For us, we use NALPAM and Visipec. That's the contrast media we use. So when you inject the contrast, you're able to see the coronary artery. And from there, you can even see the problem of the coronary artery. You can see, as I pointed in the presentation here, you can see there is a flip there. So, when you spend so time in the cath lab, you're able to be picking up like, oh, there's a dissection. The second thing which will confirm the patient who have chest pain, you say, I'm feeling my chest is, I'm having chest pain. Then that's the problem you have caused. The third thing you would look at is the ECG. You have ST elevation there. You say, oh yeah, need to sort out. But how do we sort out in a perfect way or in a better way? Let's use an IVUS. An IVUS will show you what you have caused, because an IVUS, this X-ray you can see the outside, so there is a flip there. But what will give you more information, what is happening inside the blood vessel, is the IVUS. That's why we use the IVUS. So now you can see, oh, that's my plaque here. Of course, the plaque. What should I do? I need to stent this to protect this so that the blood flow is not interfering, right? So that's how you do the IVUS. Well, there was another question. What was the next question you asked? Kalenga.
Thank you, sir. I think you've answered all of the questions I asked.
Are you sure? That's good.
Yes.
Okay.
Thank you so much.
No, you're welcome.
Mr. Mweenda, you can unmute and go ahead.
Okay. Mr. Mweenda, thank you so much. Really, this is really, I don't think in Zambia we are doing this.
No, we are doing it. We are doing it.
I stand to be corrected. Okay,
no,
that's great.
We are doing it. I'm coming to Zambia. I'm going to come to the Cath lab. So what it is, even if we are here, we need to corroborate it. This is not like an expert. No, it's learning from each other. Okay. And we are thankful for the internet now, for the new technology, we can share knowledge like this.
Sure, sure. My question comes in, I do a lot of echoes. Mm-hmm. In your situation, how relevant is echo in your situation where you have patients who presents with regional warm motion, basically suspected ischemic coronary disease, considering that Cath lab, it's an invasive, most of the procedures are invasive procedures. So how helpful is echo in your setup?
To be honest,
and if so, yes.
I have to admit, there are times we just have to stop. The doctor said, let's stop, let's do an echo. It is very important to you have in the cath lab. If you have got any issues, like even if you see, okay, got a dissection, I've done the IVUS, let's do an echo. Let's look at the left ventricle, how it is. So it is very relevant. Sometimes it's part of our diagnostic. If the patient is having chest pain on the table, you done your coronary arteries, they look fine. So then you start, what else can I do? We bring in an echo to rule out any other problem from there. So in a cath lab setup, it is a very important tool we use. And most of our physiologists who work, because in the cath lab, we work as a team. Most of them are echo trained, so they do a lot of work. So it's very, very important. And one thing, I started in the cath lab, I think some donkey years ago, we used to do left LV grams. Nowadays, we don't do LV grams. The doctor say, you know what, we are putting too many, we are giving a patient too much contrast. Obviously, when you do a LV gram, left ventricular gram, you put about 30 mils of contrast at high pressure and radiation. So most cases now, we send the patient for echo just to look at the motion of the left ventricle. So it is an important aspect of the cath lab. Have I answered your question?
Yes, you have. The reason why I asked this one, generally on echo, when you are having considering that we've got 16 to 17 segments of the heart, you tend to have this inconclusive impression, because you don't really know, those are imaginary segments.
Yes, sir.
So
yes, sir.
Half the time, like in my case, I like recommending CT angio or just to see what is really going on. So I was under the impression that when you do an echo, you may not be so specific, but cath lab will give you more information, considering that wall motion abnormalities, they are not more specific on echo.
There was one of the places I work in Reading, we had a software which was able to calculate your all motions there. And I knew it was very easy.
That sounds good.
Yeah, it was. I think if my memory serves me right, but that was 10 years ago. It's a Siemens. Yeah, so the doctors used to tell, and most of the patients, these are the people who are going for surgery. So we used to do that. Yeah. But as I said, in part of you see, when you are dealing in the cath lab, the cardiologist is not the alpha or omega. So you have to bring in other measures or other modalities like CT angio, do echo to find out what is going on, to give you the lack of a better way, the right picture of what is going on. So that's why I would say I'm not an expert in the echo. No, I'm a cardiac radiographer, and that's but when you have such kind of information, we usually get, at least now I've got this information. So I know what I'm dealing with.
Okay. No, I think I'm cleared. You've answered.
Yeah, so you are one of the valuable people who is very important in the cath lab. If we look at, even if we do the IVUS, the patient is still stented, is still having chest pain, can we do an echo just to look at the heart and find out everything is okay? So it's very, very vital tool in the cath lab.
Okay. No, thank you so much.
I think in here, it is done by the physiologist, but I know in Zambia, you guys are doing it.
Okay. No.
All right.
No, thank you so much.
You're welcome.
Okay. Thank you. Mr. Mweenda, before you go, I have a question for you as well.
Yes.
Since you do a lot of echoes, I don't know, in Zambia, are we doing spectral Doppler for echo?
Yes.
Doppler.
Maybe maybe elaborate more when you say spectral. You mean spectra or spectrum? Just generally spectra Doppler.
Spectral Doppler for echo.
Yeah, I think I've seen it with they do it somewhere here, the guys.
Yeah, but there are very few equipments in the country. I know nothing in the public unless in the private. I've seen one, but so far, National Heart Hospital, they are not doing it. Mainasoko, the software is not there, unless in maybe Pair of Health. I'm yet to know, but really,
okay.
Currently,
okay, my question came in because of what you talked about, regional wall motion.
Yes.
I think that too will be able to help too much and to be specific if we use.
I think the other thing is when you are buying new equipment, what they usually do in this country is like obviously those people like a superintendent, they would ask the band 7, they would ask us, okay, what type of equipment you want? And like we are buying Philips, and we tell them, okay, nowadays we need an IVUS integrated, we need the OCT in there, we need the FFR pressure wire there. So all those things you tell them, they get involved. But I think in our country, I stand to be collected. I left a long time ago. They bring you the equipment and they teach you what. But there is no input from the service user, the people who are using the equipment, because they know better what they want, which tools they need to be using.
Yeah, just to add on the same, I've noticed so far, I don't know in the copper belt, most of the cardiac equipment in Lusaka, where at least I'm practicing, they don't have a TDI. TDI, it's one of the good parameters to use tissue Doppler imaging to measure myocardial velocities. So you find that most of the equipments, they rely on the transmitral inflow to assess the diastolic assessment. So you can imagine the dilemma sometimes when you don't have TDI, the whole UTH, there is no TDI equipment with TDI. So really you end up doing an inconclusive, not comprehensive examination because you are lacking certain parameters. The way forward is that we are lacking people to advise, or the technocrats. They are not involved. So you find that the equipment is brought, but you can't do a proper job because certain softwares were not considered to be helpful. So I think it takes us or the people involved, the technical people to advise to such people so that we get these softwares because they really help.
Yeah, no, at least in this country, when they have to ask, they always ask your input. Obviously, you will not get everything, but when you if you have a problem in future, we told you we wanted this, but you have not given us. How do we perform our duty? So they try to, okay, and more especially like Philips, they have been very flexible. Whatever you, okay, we'll give you, okay, we'll give, okay, this one, okay, you give, because obviously one of the things, what will happen is when you advertise, well, we want to renovate our cath lab, you invite people like Philips, Siemens, GE, they would come, then they do the presentation. This is what you can give. And this, if you want, you put ad on. So it's part of them advertising. Not only just getting that contract, also. But it involves.
Mr. Mweenda, are you still here?
Yes, I'm here.
Okay, so for the TDI on the copper belt, I've seen about 3 machines in government hospitals with TDI application. The problem is like what you said. Sometimes it's people to advise because we have seen some echo. We find that maybe it needed that application to be done, but it's not there. So maybe it's just a matter of reinforcing. But however, in these private sectors, we have some machines with those applications. And the other great issue of concern is that you find that you have a machine with all those applications, but you don't have a probe. For example, at my hospital, we have a very good machine, but we don't have a probe for echo. But the application for echo, everything is there.
what I'm doing, my friend.
Yes, yes, yeah. No, I agree. And then the other thing, these softwares, they are costly. So people don't want to spend money on a software which will be underutilized. I think those are the dynamics. They are costly, they come with a fee, and so it's a multifactorial issue, in my opinion. So
I can give you an
an
example. In our hospital, we do, because of, as I explained, we do a lot when we do radio artery approach, but obviously due to spasm, we end up doing femorals. What we have done is, because in the old, some 10 years ago, people would just go blindly. They just get the landmark of the light hip, then they start. But now we have bought sonar sites. Each lab has got a sonar site. Basically, it could be used if you're using femoral access to use a ultrasound. So, because there was a justification of the ultrasound to be used when you are using femoral artery, I think it also takes in our country political will to advance those aims, what you want to achieve or what you want to get in there. It's just a lot of politics anyway. And I'm sure they don't even listen to most of our bosses at UTH, at Kitwe Central. I don't know. The modulator. Is there any more questions?
Are there any other questions before we close? I'm sure most of the people, especially maybe in our country, it's the first time they are hearing about this. Maybe that's the reason why. As you know, the setup in Zambia, maybe you only find cath lab in UTH.
Yeah,
not
I know.
any other hospital. Yeah,
I know.
So,
I know.
However, this was a wonderful presentation, so that it can open up, ideas and everything. So thank you so much for this presentation.
Yeah. So guys, I have no problem. If you want, I'll think I'll send you. Send me your email. I'll send it to you. If there are any questions, anything you want, you can email me. I'll send I think you have got my email. We can.
Sure.
So it doesn't mean, I think the world is moving closely. It's not like very soon, I'm sure you have these things. Yeah, because 10 years ago when I visited Zambia, there was no cath lab. But now there is some cath lab there, which is a positive thing. Then I think there is a bit of progress, although we can do more, but we know it's a lot to ask,
Okay, no, thank you so much. So this presentation is going to be uploaded on YouTube for those people who want to have access to it, and the soft copy will be shared as well.
Yeah.
So I think,
the other presentation I'm looking at now, there is another tool which we use in the cath lab, which when you give me I can't hear what you're saying.
you can go ahead. I think someone just accidentally.
Okay, yeah. We'll look at another tool. There are two things I've just seen. Of course, I'm also the radiation protection supervisor for the cath lab. So I can do radiation protection in theaters. Then I can do the OCT. The OCT is also to looking inside the blood vessel of an artery. But it's another equipment. Then you have to differentiate. Why do you need to do, like you guys, can I send this patient for MRI, or can I send this for conventional X-ray? So we'll look at that in the next year. I'm looking forward to another presentation.
Okay, thank you so much. So